Welcome to the International Roundtable on Vaccination, organized by the German Medical Association, the Pontifical Academy for Life, and the World Medical Association. My name is Ramin Parsa Parsi. I'm a physician and head of the International Department of the German Medical Association. You're about to participate in a compelling and extremely relevant webinar on vaccination in the setting of the current global pandemic. And participate is really the key word here, as we hope that the topics addressed today will lead to a vibrant and respectful dialogue during the panel discussion. I'll be walking you through today's event and introducing you to our excellent speakers so that you get the most benefit from the content of today's program. At the end of the webinar, you will have gotten a comprehensive summary of the major issues and challenges of vaccines and vaccinations from a global and hands-on perspective. Before I provide you with the golden rules for participating in today's webinar, I would like to disclose an important detail to you. More specifically, I will reveal why players from such different sectors have teamed up to make this event happen and why we think that such collaborations are so relevant. What physicians have in common all around the world is the primary duty to promote the health and well-being of our patients. We fight for the equitable provision of care and promote strong and resilient healthcare systems. In this spirit, it's only natural that physicians collaborate extensively internationally. And the World Medical Association has always been a cornerstone of these efforts. Another highly rewarding form of collaboration are cross-sectoral activities. With partners from other sectors and different areas of expertise, we can complement our knowledge and resources and expand our networks to contribute to the health and well-being of the people we serve. During the current pandemic, the need for such collaborations has become even more evident. But here is one more insight. In fact, the seeds of our meeting today were planted more than 2 years ago when we agreed to join forces to address the challenges of global vaccine equity and vaccination hesitancy. We saw the vast opportunities this extraordinary collaboration could provide in our efforts to build trust, raise awareness, and achieve broader dissemination of accurate and understandable information on vaccines. Although we couldn't go ahead with an in-person meeting as originally planned, we remain determined to host the meeting in the form of a virtual roundtable. I would like to thank all our speakers and participants for their flexibility and commitment. Let me also add a word of thanks to our co-organizers for an extremely pleasant and fruitful collaboration. I'm especially grateful to my colleague Siobhan O'Leary for all her hard work. Thank you. Now, we will start with some brief remarks by the presidents of all the 3 organizers. We will then proceed with our 3 keynote speakers who will present for about 10 minutes each. We invite you to reserve your comments and questions for the panel discussion and Q&A following all of the keynote presentations. The panel discussion will feature a commentary from an additional distinguished expert and will be introduced and moderated by the WMA Chair of Council. I will introduce the first speaker in a moment, but let me now share with you the golden housekeeping rules. All speakers and panelists will be able to turn on their cameras and microphones individually. I would like to ask everyone to mute their microphones unless they're about to speak. This will improve the sound quality immensely. During the panel discussion, you may raise your hand in order to make a comment or pose a question. The moderator will then grant you speaking privileges. We will activate your microphone, but you will still have to unmute your own microphone as well. You won't be able to turn on your camera. Please don't forget to introduce yourself with your name and affiliation. You may also type your question into the chat box. If time allows, we will also consider some of the contributions from the chat. Well, now at this point, I would also like to point out that this session is being recorded and may be published. If you prefer that your contribution not be published, kindly let us know. Okay, now it's my great privilege to introduce the President of the World Medical Association, Dr. David O. Barb. Dr. Barb is a board-certified family physician in the US who also served as the president of the American Medical Association from 2017 to 18. Dr. Barb, the floor is yours.
Thank you very much, Dr. Parsi. And thank you for tuning in today to participate in this extremely important conference, a workshop. The WMA is very pleased to be able to partner with the German Medical Association and the Vatican to bring this to you today. We would not be here today if our vaccination rates around the world were where they should be. But as we all know, they are embarrassingly low, and all steps must be taken to try to remedy that situation. The World Medical Association has had strong policy on vaccines for a long time. As we all know, the vaccine hesitancy that we will discuss today is not new with the COVID vaccine. We have seen that evolving and becoming a louder voice around the world with respect to many other vaccines. One of the critical reasons that this needs to be emphasized is that for many of the diseases for which we have vaccines, there is no direct treatment. And so when there is no direct treatment for the disease itself, it is especially important, and I would say critical, that we promote the vaccinations to prevent the disease or reduce the severity of the disease that we cannot otherwise treat. The WMA has also had longstanding policy regarding how we should prepare for epidemics and pandemics. This COVID pandemic, while the worst we have seen in our lifetimes, is certainly not the first, and we know it will not be the last. We have learned much from this pandemic. I hope and I pray that we will put into practice some of the things that we have learned, that we will do a better job with public health preparedness, that we will lay a groundwork for even greater collaboration and cooperation between countries and between governments so that we can do a better job the next time we are faced with some similar issues. As we all know, very early in this pandemic, questions arose about how long it would take to develop a vaccine and how would the vaccine be distributed once it were available. We also saw a very natural, I would say, human response, and that those countries that were more affluent and had the ability to do so put in advance orders for vaccines. There was always the question of what the production capacity would be, and would other countries, the so-called third world countries or countries with fewer economic resources, would they have access to the vaccine? And as we have seen, those fears have played out. There are many countries that, for a variety of reasons, have not yet had access to the vaccine, and therefore those vaccination rates are in some countries negligible. We understand that this is a pandemic that does not affect just one country, and therefore the response to this cannot be parochial, cannot be focused on just one country's ability to obtain or distribute the vaccines. So we must work together. We must collaborate in the way, a model of COVAX, for instance, to assure improved and equitable distribution. I want to close with just a couple of considerations, and that is we will be, in today's discussion, focusing very much on what I would call the individual response to vaccination, and that is critically important. We can have all the infrastructure, we can have all the supply, but if the individual himself or herself is not yet prepared to take that step and be vaccinated, then the rest is for naught. However, all of those other steps are critically important. And while we cannot cover them all today, in my mind, a framework needs to be kept in mind so that as we hear from our expert speakers today, we can continue to think about how this fits into the overall structure of vaccine distribution. One step, of course, I've alluded to already, is access to supply. There are countries that simply do not yet have access to that supply, and we need to continue to work diligently to make sure distribution is available to countries that need it. Second, once the vaccine is available, the distribution within a country is critical. And there are many countries that simply do not yet have the infrastructure in place for efficient and effective distribution of vaccines. And also prioritization. If the infrastructure exists, then who should get the vaccine first? How should that be allocated and distributed? I think a third level then is what I would call affordability and access. In many countries, the vaccine has been made very affordable, but that is not true in all countries. So we must continue to work on the economic impact on the individual not being a barrier. And then, of course, access. We have many countries in this world that have very remote and rural populations, and even countries with some good infrastructure can have difficulty for a variety of reasons getting vaccine to the individuals in their country. And lastly, we will spend time today talking about what is often called vaccine hesitancy. And I'm very eager to hear Dr. Ammon's comments. The concept of vaccine confidence, I think, needs to be emphasized. And we have seen, unfortunately, the lack of persuasion when we only emphasize the misinformation or the disinformation and try to, quote, debunk those myths. While that is a very important part of our approach, it will not necessarily win the day. And helping people be confident in the vaccines, see the benefit of the vaccines, be able to make an intelligent risk-benefit decision for themselves, I think will be critical. So with those words, again, I am extremely excited to hear from our speakers today. And thank you all for joining. Perhaps since this is virtual, we will have had an even broader audience than we would have been able to have had it been a live presentation. So thank you very much. Dr. Parsi, back to you.
Thank you so much, Dr. Barb. All right, now I'm honored to introduce Dr. Klaus Reinhardt, who has served as the president of the German Medical Association since 2019. Dr. Reinhardt has been a practice-based specialist in general medicine for 25 years. And I think, Klaus, you're turning in today from Vienna, if I'm correct, right? The floor is yours.
Yes, thank you, Ramin, for the introduction. Good morning, good afternoon, and good evening everywhere. Dear Arcivescovo Monsignor Paglia, dear President Dr. Barb, distinguished speakers and guests, dear colleagues, I would like to join my colleagues in warmly welcoming you all to the International Roundtable on Vaccination. Let me start by saying what a great honor it is for the German Medical Association to have the opportunity to collaborate with the World Medical Association and the Pontifical Academy for Life to bring this important conversation to you today. This is our second joint conference, and we hope this tradition will continue. For most of us, It has been for most of us, it has been more than a year since we have attended any international meetings in person. In the case of today's roundtable, we were looking forward to gathering in the beautiful home of the Pontifical Academy of Sciences at the heart of the Vatican Gardens. This wasn't meant to be, but we are still pleased to have participants from so many regions of the world joining us virtually. Today, we will explore two very important issues: global vaccine equity and vaccine hesitancy. We will also look at the role the medical profession and religious communities can play in addressing these issues. As this year's German Medical Assembly in May, the German medical profession passed a resolution in support of global vaccine equity. Delegates called upon the German Bundestag and the European Parliament to waive COVID vaccines patents temporarily while ensuring fair compensation for the intellectual property of the patent holders. A proposal to lift patents was first introduced last year to the World Trade Organization by South Africa and India. Although the German government and European Commission currently support alternative approaches, including limiting export restrictions, we hope that with increasing pressure, they will become more engaged and do justice to Europe's global responsibilities. Of course, speeding up global production of vaccines also requires a transfer of knowledge, technology, and manufacturing expertise. The need to take immediate action is clear. While vaccination rates are increasing in more economically powerful countries, COVID-19 cases numbers and fatalities continue to climb in parts of the world where vaccines are in limited supply. We must achieve the highest possible vaccination rate worldwide as quickly as possible. And I think we can all agree that this should not be dependent on a country's economic influence. The response from wealthier countries must also include greater support for the COVAX initiative. The global success of the COVID-19 vaccination campaign is also the key to preventing the development of viral mutations that could undo the progress we have made on global vaccination. Another threat to this progress is vaccine hesitancy. This is a very complex issue, which is influenced by many factors. But one thing is certain: the medical profession has a tremendous responsibility to counter disinformation and build public trust in vaccines. One way we can meet this responsibility is by working across disciplines and cultures to amplify our message about the safety and importance of vaccines. And that is one of the reasons why the German Medical Association decided to join forces with the World Medical Association and the Pontifical Academy for Life. Through this unique collaboration, we hope that our message will resonate with a broader audience, from medical professionals to religious communities, vaccine producers, governments, and other stakeholders worldwide. As author and Professor Euler Biss wrote in her book on immunity, immunity is a shared space, a garden we tend together. While we may not be having this discussion in the Vatican Gardens as originally planned, we can still tend to this shared space by exchanging knowledge to improve confidence in vaccines and raise awareness of the barriers to vaccine equity. Thank you for your attention.
Thank you so much, Dr. Reinhardt. And finally, it's my great pleasure to welcome Archbishop Monsignor Vincenzo Paglia, President of the Pontifical Academy for Life. Monsignor Paglia was appointed to this role and to the role of the Grand Chancellor of the Pontifical John Paul II Institute for Studies on Marriage and the Family in August of 2016. Monsignor Paglia, it was great pleasure working with you in preparation of this event. The floor is yours.
Sound, please.
Stop.
I think now we can hear you.
Okay.
Please go ahead. Thank you.
I would like, first of all, to express how grateful and pleased I am that we are sharing this time of deep reflection and dialogue. This is all happening thanks to cooperation between the World Medical Association and the Pontifical Academy for Life. An important reason to be happy is the fact that we are not taking part in just on a time event, on one-time event. Today's webinar is a follow-up to our earlier meeting in November 2017, when we took up the difficult issue of euthanasia. We examined the problem in depth and from different perspectives, revealing the many objections that medical ethics has put forward with regard to this practice. Realizing the positive effects that conference produced, we began immediately to plan this one. Actually, we had long been thinking about a conference on the general subject of vaccines and had made progress on it even before the pandemic broke out. We saw clearly how important the subject is. Unfortunately, however, the current difficulties forced us to reduce the dimensions of this meeting, to limit its scope, and to hold it online. As we know, today's meeting will deal only with vaccines against COVID-19. Nevertheless, and this too is a reason why we are grateful and pleased, we have overcome many obstacles that have made our daily lives difficult in recent months. And our original project, a conference that addresses the whole spectrum of vaccine-related questions, has only been postponed, not abandoned. In Rome or in Latin, we used to say, quod differtur non aufertur. Today's webinar presents us with the possibility of cooperating with all persons of goodwill in the pursuit of common goals. This does not mean ignoring differences, but neither do we want differences to block initiatives that protect health and life, especially that of persons who are made weaker and more vulnerable by reason of social, national, and international injustices. It is important to unite our voices and our strengths so that vaccines can be made available to all those who need them. This is a commitment that will ensure that our declarations about wanting to overcome inequalities and injustice do not remain a dead letter. We are also committed to providing correct and credible information about there being no reason to entertain either scientific or ethical doubts about vaccines. The effects such doubts produce are dangerous and negative for everyone, not just for those who decline to be vaccinated. Even Pope Francis has spoken to this point on a number of occasions, reminding us that vaccination is about not only one's own health and that of others, but also about the common good and justice. I quote, "If there is a possibility of curing a disease with a drug, it should be available to everyone. Doing otherwise gives rise to injustice. There is no place for medical marginalization." End of the quotation. Pope Francis continues, I quote again, "Globalized social and economic differences risk controlling the way anti-COVID vaccines are distributed, with the poor always coming last and right due to universal healthcare, which everyone accepts in principle, being emptied of any real values." End of the quotation. To conclude, I sincerely hope that this meeting can contribute to the realization of the goals we have set for ourselves, so that we can put into practice with a greater conviction and accountability that mutual support that makes our life together on this planet more human and more fraternal. Thank you very much.
Thank you so much, Monsignor Paglia. Thank you. Well, and now I'm delighted to welcome our first keynote speaker, Dr. Andrea Ammon. She's director of the European Center for Disease Control, which is located north of Stockholm in Sweden. Prior to joining the ECDC, she served in several roles at the Robert Koch Institute in Berlin, most recently as head of the Department for Infectious Disease Epidemiology. I'm so pleased that Dr. Ammon has joined us today to speak about vaccine hesitancy. Welcome, Dr. Ammon, and the floor is yours.
Thank you very much, dear Dr. Parsi. And I share now my screen, hopefully. Dear Dr. Barb, dear Dr. Reinhardt, dear Archbishop Paglia, dear colleagues, I'm very honored to be today at part of this event, because I think the topics are important enough to be dealt with in such a circle. We have been working with vaccine hesitancy since several years, but of course, the pandemic, as with so many other things, has given it a particular importance. A pandemic has taken an unbelievable toll in human lives and has forced countries around the globe to unprecedented and unimaginable measures to protect and save people's lives. Now, since half a year, we have vaccines that give us hope, and still we are struggling. That has been is the case partly due to the availability and the uptake of the vaccines, but also with other aspects, some of which I will go into. And I would like to highlight in one particular aspect why this is so critical with the vaccines. We have currently a quite favorable situation, epidemiological situation in the EU. Only in 5 countries we see a reason for concern. But then there is the variants. Currently, the variant of most concern is the Delta variant, which is increasing in the EU, and it is 40 to 60% more transmissible than the Alpha variant. That is already 50% more transmissible than the original strain. So we estimate that at one point in August, around 90% of the new infections will be due to this variant. And then the question is, do the vaccines work against these variants? And the evidence so far says, however, it requires a full course, meaning a double vaccination. If you have only one dose, the effect of the vaccine is quite low. That highlights the importance of a full vaccination here. And this question will be asked for every new variant that we might encounter in the course of this pandemic. Now, the hesitancy has been recognized as an important problem. It's not new. It's not only due to the COVID vaccines. It started actually already with Edward Jenner and his smallpox vaccine. So the more recent examples I have listed here, it's the Council recommendation from 2018, which determine much of our current vaccination work. And already on the first page, you see here on the left side that the spread of misinformation is highlighted. I will come back to this. That is instilling doubts and questions into people that have not the full picture and overview and knowledge about how vaccines work. And the second part that I would like to highlight is that it lists healthcare workers as the key, having a key role in working towards the goal of improved vaccine coverage and confidence. And we have to keep this in mind if we want to do something against the hesitancy. You also see on the right side that WHO has listed vaccine hesitancy as one of the 10 biggest global health threats. Now, when we're talking vaccine hesitancy, it has many aspects, and not everybody who is not vaccinated rejects vaccination. There are very several aspects. One is the confidence. It has been mentioned already. It is the trust in vaccines. Do they work? Are they safe? And can I give it to my children? Can I give it to my old parents? And that is in particular with new vaccines. And that's what we're seeing also with the COVID vaccine. The other element is complacency. People think, well, I have no risk for severe disease. It's just a flu-like syndrome. So why should I get vaccinated? So that's really a lack of knowledge. And the last one is convenience. And that has the range from really, well, I can't go to the doctor, it's too far away, to really populations that are hard to reach, to now what we are seeing in the world, that some even continents don't even get the vaccine. So that's a large part. And then there is, of course, the small group, approximately 5% hardcore people that are rejecting vaccines. Now, those three components can be addressed. The hardcore rejection is very, very unpromising to address. So the efforts should really go into these three areas. Now, there are a lot of questions, especially with the new vaccines. Are some vaccines better than others? That is a question that is now very prominent because we have also other diseases where there are different companies providing the vaccine, but it's not as much in the spotlight as for COVID, where each new vaccine authorization is hailed as progress. So people are much more aware that there are different vaccines. There are also different mechanisms how they function. So that is why the question is asked. Now, how long will the protection last? That is a question that we cannot answer right now because it will depend on the observation time. Are the vaccines safe? Also here, there might be effects that only come when there are really a lot of people vaccinated. Are the vaccines effective against variants? I mentioned that already. This question will come and will be virulent for every new variant of concern. Do we really need two doses of this vaccine? Very important to make sure that people get the full course. Those who don't risk severe disease, do they really need to get vaccinated, addressing the complacency component? And are the vaccines effective? So these are questions that are coming up always with vaccines, but here with new vaccine like the COVID vaccine are of course even more in the spotlight. Now, there are some specific issues around vaccine hesitancy of the COVID vaccine. One is product-specific concerns. In our monitoring that we have on a regular basis, and the latest report is published 2 weeks ago, we show that in 12 countries, so that's almost half of the EU, we have specific increase of vaccine hesitancy regarding the AstraZeneca vaccine. Where individuals refuse the vaccine, but only that one, not in general. So here the countries indicated that there are communication and information activities ongoing in order to support the increase update and to address misconceptions regarding these vaccines, the safety concerns, the effectiveness, and also the uncertainties regarding the second dose. The second dose is also in general an issue that some people do not come to the appointments for the second dose, and there are specific to make sure that people get the full course. As I mentioned it, especially regarding the Delta variant, it's very clear that the second dose at full course provides very good protection, whereas one course does not. Then we have migrant communities that are even more susceptible to misconception, to misinformation because of the language barrier and social exclusion. So some of the information may not reach these communities. So here are specific efforts necessary involving the communities in the communication effort. But there are other vulnerable populations, and I mean here specifically socially vulnerable populations where the same effort has to be done as well. And lastly, there is misinformation and disinformation that is spread online and can quickly change narratives that can emerge and evolve, and they can affect control efforts. So I will come back to this because we have recently published a report on this. Now I want to show you the Eurobarometer. This is a survey that's regularly done in the EU over all countries, and that is the most recent one from May, where you can see that overall in the EU, around 80% of the participants in this survey said they have either already been vaccinated, want to get vaccinated as soon as possible, or at one point in 2020. And the reasons why they want to get vaccinated is that it can help to put an end to the pandemic. Actually, the most frequently mentioned reason, that the vaccine will protect others from getting COVID, and it will make it possible for me to meet family and friends. So sounds very encouraging and very positive, but when you look a bit more closely in the country, you see there are vast differences. And if you go at the right end of the scale, you see Bulgaria, where only 31% actually want to get vaccinated as soon as possible or have been vaccinated already. And almost as many say, I want never to get vaccinated. So there are really huge differences between the countries, and they have to be tackled with the specific situation in the countries. So what can be done and has to be done now is definitely to understand what is driving the hesitancy to get vaccinated. Is it a complacency? Is it convenience? Or is it the confidence? And then try to address and tailor the interventions to specific populations. Involve those populations, and with leaders from these groups that have much more the confidence of these people and are more credible when giving the message. But it's also to support healthcare providers in their communication with the patient. Because, I mean, being a healthcare provider not necessarily makes you self-immune against hesitancy and questions. So they need to have all the information so that they can also then give good advice to the patients. So particular topics that need to be taken up in the communication is the importance of the vaccination. So the positive effects of the vaccine, the support to family and friends. So if they have any issues and questions, make it clear it needs the full vaccination course, addressing misinformation, and saying where the vaccine is available and how people can actually get vaccinated. Here you see some of the resources that we have produced. These are the three the ones that we have done in June, but you have seen we have already supported the countries with vaccination and prioritization strategies in collaboration with all the national immunization technical advisory groups. But that's sort of the most recent part. It's only 2 days on the market. It's countering online vaccine misuse in the EU EEA. This is a project that we have commissioned long before the pandemic, but last year we have added the COVID vaccine to the other 5 vaccines that were already, or 4 vaccines that were already part of the program. And here it's very clear, monitor what are the messages that are going around in the social media. So you have to know the enemy before you can actually address what is circulating, and then correcting. And I fully agree, debunking is reactive. You always run after what has been put out. It's more looking at the trends and making it clear to people this is actually what people will say, and this is why it's wrong. So it's called inoculation, which I find particularly fitting for a vaccine. So it is basically getting people immune against these false messages. Then, of course, it's important, but that's a more longer term thing, to enhance and promote people's digital health and science literacy. And very important is to evaluate the effectiveness. What done, because we have a catalog of measures against vaccine hesitancy, and very few of them have been actually evaluated. So then here, that's our European Vaccination Information Portal, where we have information that together with the Medicines Agency on the COVID-19 vaccines, it's available in all official languages. And I can tell you the languages where we have most hits from is Greek, Romanian, and Hungarian. So it's very clear that it's necessary to provide such information in the national language. So to conclude, the summer season is upon us. Everybody wants to be out among people, but then the virus is still there. We have the variants, a relaxation of non-pharmaceutical interventions could be quite detrimental and should be done with extreme caution. Also because the vaccination rates are suboptimal, even in our continent, let alone in the rest of the world. There are challenges in access and vaccine uptake, which we will soon hit ceilings. Right now, the progress is still measurable every day, but we will hit the ceilings and have vaccinated all those who want to get vaccinated. And we have to see an outreach to those who are not yet vaccinated. And that means and includes addressing misinformation and disinformation. I can go into more details, but I stop here and thank you for your attention.
Thank you so much, Dr. Amon. Thank you. This was very interesting and rewarding. I would like to remind everyone to reserve your comments and questions for the panel discussion, which will be held and introduced right after all three keynote presentations. All right, let's move on then. I'm so delighted to welcome our next keynote speaker, who will share her expertise on global vaccine equity. As chief scientist of the World Health Organization, a pediatrician from India, and a globally recognized researcher on tuberculosis and HIV, Dr. Soumya Swaminathan brings with her 30 years of experience and research. Welcome, Dr. Swaminathan, and the floor is yours.
Thank you. Thank you so much, Dr. Parsi, and thanks to the organizers as well. And I'm glad that I could catch some of Dr. Andrea Amon's presentation, which was very insightful. I will try to give a brief global overview of the issues around vaccine equity. And I'm going to try to share my screen now so that I can have a few slides, and I hope you can see that. I'm going to put it on slideshow. Yes, and I hope you can see my slides now. I want to start by showing you this map of the about 3 billion doses of vaccines that have been administered to date. And you can see the darker the green, the more the vaccine coverage of the populations. I should add that
I'm sorry, Dr. Swaminathan, we can actually see all your slides. I think you might want to start the presentation mode.
Yes. That's what I was trying to do actually from the beginning, but it's going to the other screen now. So let's stop sharing. Okay. problem is that it's sharing the wrong screen. Okay, let me share this.
All right, this looks good.
This looks
Perfect.
okay? All
yeah,
right.
this looks nice. Thank you so much.
So you see the world map now?
Absolutely, it's wonderful. Thank you.
Okay, so only 5 countries have not started the campaign, but of the 3 billion doses now provided worldwide, these countries you see here on this map are the ones that have received doses from COVAX. Unfortunately, it's a small amount so far, about 90 million doses to 133 participants. So we have a lot of participants in COVAX, both the AMC countries, which get it free, as well as the self-financing participants. The problem has been the supply into COVAX, so that because of which we have not been able to send out the millions, hundreds of millions that we had wanted to by now. Of course, a few countries are dominating, and you can see that 10 countries administer almost 80% of all doses, and China is at the top of that list. Of the WHO's 194 member states, I mentioned that 5 countries, 3 in the Afro region, 1 in PAHO, which is Haiti, and the DPR Korea, which is in the Sierra region, have not yet started. But some of them are in the process, particularly the ones in Africa that are Eritrea, Tanzania, and one more. Again, if we look at the state of vaccine rollout by income levels, again, we see that as you get into the lower income countries, even though this is a bit misleading because it looks as though the majority of countries have started vaccinating, but it's the coverage that really you can see in this slide. If you look at the share of the countries that have a coverage of over 20% of the population with the 2-dose regimen, we see that as you get into the countries that are in the lower socioeconomic scale, you have less and less countries with high coverage. And again, I will skip through some of these slides, but this one shows you that the AstraZeneca vaccine is the one that's most widely used. Of course, the AstraZeneca vaccine is being made in different regions. It has 2 names, the Vaxzevria that's made in Europe and the UK, and the Covishield that's made at the Serum Institute, but it's the same vaccine really. And one of the issues, in fact, just now, today with the start of the vaccine certification program in Europe is one of the issues that we are dealing with, is the fact that both of these need to be recognized as equivalent vaccines because they are the same. The next most commonly used is the BioNTech Pfizer vaccine, followed by Sinopharm, Moderna, Sputnik, and so on. Again, this is another way of just showing that so far of all the doses administered, while the low-income and LMIC countries represent 46.7% of the world's population, only 14.4% of doses have been administered there. And this is a very stark way of showing that if you look at cumulative doses administered per 100 population, you can see the wide difference between the groups of countries. And in fact, if you take those 2 countries, the US with 95 doses per 100 population and Nigeria with 1.2 doses per 100 population, you see the difference really, which is something that we are trying to address. So the gap in coverage is widening, even though if you just look at countries that have started vaccinating, it looks as though most countries in the world have started vaccinating. And it's similar inequities with diagnostics and treatments. It's not just vaccines. So low-income countries are doing the high-income countries are doing 125 times more tests per day than low-income countries. And we've seen also the shortages of oxygen supply, not just in Africa, but in many countries. So there is really, all of this is telling us there is a need to also improve in the longer term sustainable manufacturing capacity for vaccines, therapeutics, and diagnostics. So we are leading several initiatives to tackle this issue, of course, by monitoring the pandemic through the dashboards that all of you are familiar with, the member state briefings, the press briefings that we do on a regular basis. Our regulatory colleagues have for many years been engaged in training of national regulatory authorities, as well as on ethics guidance to build that research capacity. The R&D blueprint has been also working on priority pathogens for many years after the Ebola outbreak, in fact, from 2016 onwards. But we've now been working with several networks around the world, and the blueprint has been coordinating a lot of R&D activities. The ACT Accelerator has been mobilizing resources for the diagnostics, therapeutics, vaccines pillar. And then I will tell you a little bit about the manufacturing task force that's been recently set up by COVAX to address the longer term issues. We've, of course, you've seen the dashboards, but we're monitoring not just COVID, but also the impact of the pandemic on other essential health services. And I think we mustn't forget that the pandemic has had a huge impact on the delivery of essential health services. And again, when you compare high income versus low income countries, you see it's the low income countries that have the least resilience in terms of being able to mobilize workforce and mobilize resources. So immunization programs, antenatal mother and child programs, non-communicable disease, mental health services, essential surgery, blood transfusions, all of these have suffered. And therefore the excess mortality that that countries measure will actually tell us that it's not just the direct effect of COVID itself that caused deaths, that caused morbidity, but it's really the impact on the health system as a whole that would have resulted in excess deaths due to a number of other diseases that did not receive treatment in time, whether it's TB or whether it's cancer. Again, on ethics, we set up an international bioethics working group that's been looking at the different ethical challenges and dilemmas from vaccine supplies and how do you prioritize groups to receive limited vaccines, to tracking, digital tracking technologies, the ethics of all of these new digital tools, human challenge studies, etc. I mentioned the R&D blueprint and the work that's been done from early stage preclinical all the way to post-licensure, and the solidarity trial that was set up last year to test therapeutics and has involved a large number of countries worldwide. Again, now with the variants that are becoming more and more common and spreading quickly around the world, we've set up this risk management, assessment and management effort where a lot of inputs from our different working groups come into centrally into a coordination mechanism that will really try to inform not just the public health actions that are needed, but also research agenda and whether vaccines should be modified to respond to the new variants. And finally, on the manufacturing task force, we've got this between the COVAX partners, 4 work streams, but the work stream 3 is the one that's being led by WHO to set up sustainable capacity particularly in LMICs. And we are working currently on establishing the first mRNA technology transfer hub in South Africa. There will be more hubs later on, but the first one has been selected to be in South Africa. We're working with a number of partners, including the European Commission, as well as many member states, the World Bank, and of course the African Union to make this a reality. And the idea is really to establish one hub, but as a consortium of inventors, researchers, developers, the member states, the IP holders, the private sector. And then that particular hub can then be a place where other countries' teams come for training and they receive the technology, they receive the training, they can go back and set up facilities to scale the production, not just of mRNA, but hopefully of some of the other new technologies that have proven to be quite effective. And so it's a process, it's going to take a bit of time, but hopefully it will serve well beyond the COVID pandemic to address the needs for health products, whether it's vaccines or monoclonal antibodies or drugs, to be produced in regions of the world which currently lack these kind of production capacities. So in response to the expression of interest that we launched, we got a number of responses. And as I mentioned, South Africa is the first hub that was announced on the 21st of June. And we are now working with the technology companies that have offered their technologies to select the most promising ones that can be then taken into this hub. And over the next few months, we hope to be doing much more intensive work in this area. I will stop there and turn it back to the chair. Thank you very much for this opportunity.
Thank you so much, Dr. Swaminathan. We are very grateful that you could join us today. The topics we're discussing today raise some very important ethical questions as well, which is we are fortunate to have Professor Stefano Semplici joining us today. Professor Semplici is a professor of social ethics and a member of the Faculty of Philosophy at the Tor Vergata University of Rome. He was also chair of the UNESCO International Bioethics Committee from 2011 to 2015. Professor Semplici, thank you for joining us, and you have the floor now.
Thank you for giving me this opportunity to share ideas and reflections on such a relevant topic. A pandemic is a matter of individual health as well as public health. Vaccines against the SARS-CoV-2 protect the former while protecting at the same time the latter, because they make it more difficult for the virus to circulate. This is quite obvious and has been already underlined many times this afternoon. This is therefore why the primacy of individual freedom of choice, which has become the pillar of medical ethics, should necessarily be made consistent with the responsibility that all citizens should share for the common good, whatever the common good is likely to be considered. I suggest to take the notion in a very general way with regard to the topic we are discussing today, that is minimizing the number of deaths, of suffering, and more in general, the impact of the burden of the pandemic on the well-being on communities and society as a whole. The relational character, this is the first point I would like to make, of autonomy emerges clearly. My choice has a relevant impact, not only on myself. My choice has a relevant impact, not only on myself. The same at the community level. The choices, the decisions made by my community have an impact, not only on my community, on our communities. A confirmation of this observation is also the fact that the issue of respecting the exercise of individual freedom went hand in hand with that of respecting and protecting everyone's dignity from the very beginning of the pandemic, as two sides of one and the same coin. Just to summarize, in the first phase of the pandemic, we had on the one hand, especially in some countries, in the rich countries, a strong debate on criteria for triage in case of mismatch, tragic mismatch, as it can happen in disaster medicine situations, in case of a mismatch between needs and resources available, be it about ventilators or beds in intensive care units, and so on. We all remember the burning issue. Only medical criteria to be considered for triage. At the same moment, on the other hand, we were perfectly aware of the fact that exactly the need to ensure physical distancing led to heavy restrictions on the freedom of movement and other rights that are essential constitutional rights, not only in Western society. It is worth observing that in the very same document where an insurmountable ban seems to be put against using criteria other than medical ones for triage, a relevant warning was also included about systemic threats. The economic consequences were thus mentioned by Deutsche Ethikrat in its recommendation on solidarity and responsibility during the coronavirus crisis of March 2020. The economic consequences were mentioned together with the socio-psychological ones, and the impact on the elementary conditions of a democratic culture. A serious social debate was wished for in order to evaluate in a dynamic way the impact of the pandemic on the prerequisites of a functioning community, and to decide which life risks a society is willing to classify as acceptable and which is not. That is to highlight the very important fact that it is never just about science. It is always about ethics and therefore about politics. I will come later to that. Vaccines raise different and as challenging questions. On the one hand, the issue of equity, as we have seen. And we should deal with such an issue in a broader scope. Equity can entail many different things, many different aspects. Just to share with you an example, in the guidance on the prioritization of key populations for COVID-19 immunization, by the National Advisory Committee on Immunization of the Government of Canada, equity is defined entailing efforts that should be made to increase access to immunization services, to reduce health inequities, which cut further significant stigmatization or discrimination, and to engage systematically marginalized and racialized populations in immunization program planning. It is not just about something that happens among peoples, but within peoples and states at the domestic level as well. But on the other side, and I come to the very burning issue I would like to share with you, we are confronted with a possible conflict between the duty to respect individual freedom and the duty to promote the common good. That is, as I said, to protect the public health as well as the socioeconomic well-being of the community. We know that it is necessary to vaccinate as many people as possible, as it was underlined, both for protecting everyone's health and restore the normal conditions for economic activities and societal interactions. But many people are not vaccinated. Some people could refuse the vaccine, and their right to do it is widely recognized. This is where a risk of an irremediable contrast between individual freedom of choice and common good can become a looming one. The key words that are being used are well known. I would say maybe very well in the theory, maybe even too much in the theory, wishful thinking in the practice. It is about trust, public trust and confidence. It is about solidarity. About trust, the European Commission, in a communication to the Parliament and the Council in October 2020, wrote, October 2020, concerning the sufficient uptake of safe COVID-19 vaccines, it is already important to start building public confidence in vaccines. The lack of confidence, as in the recent past, led to an insufficient uptake of, for example, key childhood vaccines and consequently new outbreaks of vaccine-preventable disease. This is not a new phenomenon. As underlined in the Commission communication tackling COVID-19 disinformation, misinformation, and disinformation around the possible COVID-19 vaccine has not slowed down and will likely make the eventual deployment and uptake of vaccines more difficult. Unfortunately, this is what largely happened. Solidarity. In very interesting document worked out by the Vatican COVID-19 Commission in collaboration exactly with the Pontifical Academy for Life. A statement by the bishops of England and Wales was mentioned. In this statement, it was reaffirmed that individuals should welcome the vaccine, not only for the sake of their own health, but also out of solidarity with others, especially the most vulnerable. And the reasons why have already been recalled. So, trust, confidence, we are called on to do the best we can. All our efforts are required to improve trust, confidence, and to look at solidarity as a matter of social, political justice, not just as a matter of top-down beneficence. But then, what happens if we do not succeed? At least we do not succeed to the extent that would be required. This is where we bump into a burning issue, a question that everyone would like to avoid. But in such a debate, we have to address also this question, maybe to answer no, to answer something else, but it is something to be debated, even, I repeat, to reaffirm what is already known and has been done so far. I'm Italian, so I look at Italy as an example. Article 32 of the Italian Constitution reads as follows, very clearly, no one may be forcefully submitted to medical treatment unless provided for by law, unless provided for by law. This means it is not absolutely impossible. In no case may the law violate the limits imposed by respect for the human being. According to the Italian Committee for Bioethics, an opinion to some months ago, after making all efforts to achieve and maintain optimal vaccination coverage through conscious adhesion, the possibility to make vaccination mandatory, quotation, should not be excluded, especially for professional groups that are at risk of infection and transmission of viruses, end quotation. How to decide if the time for obligation has come? Who should be entrusted for such a heavy, grave decision? This is something to be discussed. Maybe, hopefully not necessarily for this pandemic. However, I think it is about preparedness for the pandemics that could come, we hope not, but that could come in the future. And I come to my conclusion. Individual freedom and the common good. It is always a bad thing where we are not able to bring them together. And a pandemic crisis is where they should be brought together more than ever. I come back to the idea of solidarity. As I said before, solidarity should not be looked at as just a matter of top-down beneficence. Vaccination, all the more so a mass vaccination campaign, is not only a scientific issue and should not be looked at as just a scientific issue. It is a matter of ethics, it is a matter of anthropology. To quote Immanuel Kant and put it in philosophical words, what can I know? What ought I to do? What may I hope for? The hope we decide to share highlights the point where individual freedom and the common good converge. It is always up to us to decide. To put it in more concrete words, let me quote a passage from the report of the International Bioethics Committee on Social Responsibility and Health finalized in November 29. Solidarity requires an idea of shared life or destiny. It also requires a sense of belonging, integration, or rootedness of each individual member within the group. What group are we talking about? The group of ours, first my country, or humankind as a whole. This is, I think, the very difficult challenge we are confronted. It's a challenge not to miss, but to address in the proper way. Thank you.
Thank you so much, Professor Semplici. We really appreciated that you could have joined us today. Well, now I'm sure many of you have had the chance to think of some interesting questions for our speakers. But first, I would like to welcome Professor Frank Ulrich Montgomery. He's the Chair of Council of the World Medical Association. He is also the President of the Standing Committee of European Doctors. Professor Montgomery will share his own findings of the meeting thus far before introducing another special guest to our program and leading us into the panel discussion and questions and answers. Thank you, Professor Montgomery. The floor is yours.
Thank you, Ramin, and a great round of thanks to our three speakers up to now, because you have really given us a wonderful introduction into the topic which we are going to discuss with our learned audience. First of all, I found it extremely interesting to see in the speech of Andrea Ammon that on the issue of vaccine hesitancy, we have to fight the important and difficult issue of confidence, complacency, and convenience. They are an obligation for us as the medical profession to be fulfilled and to talk to our communities, to be able to get an acceptance of vaccinations, because I think this is one of the issues, even though Professor Semplici may have had a slightly different tone to it, that we will not be able to achieve obligatory or mandatory vaccination at present time. Had the virus been an Ebola virus with the lethality of a mortality of an Ebola infection, this might have been different. But I think there is one thing we should also not forget, and that is the prevention paradox. The better we are, the more people are complacent and think it's just a flu, it's just a small infection, and will not go into vaccination. Professor Subimatan from the WHO gave us an intriguing insight into equity. 3 billion doses have already been administered, but 80% of these were administered in 10 countries. And the rate of vaccination in low-income countries is 62 times less than that in high-income countries. And she highlighted a very, very important issue, which is also a thriving force for us to change these issues. Many other healthcare services have suffered. We have also seen an indirect impact of the corona pandemic, and I think this is very, very important. And she's mentioned also, and I think Klaus Reinhardt mentioned it in his introductory remarks as well, the question of patent upheaval or of producing the vaccines in the countries where they are needed. And I think it is a very, very important move, as it will probably be very difficult to decrease the patent rights, to get production hubs in low and middle income countries together with the researching and developing pharmaceutical industry and the specialists from the companies, because it is not trivia that the production of a vaccine is more than difficult and needs specialists from the researching countries. And finally, Professor Semplici gave us an extremely interesting insight into individual freedom. And of course, as a German, I enjoyed his quotations of Kant at the end, and the basic idea that individual freedom and the common good have to be brought together. It is a very difficult challenge in a changing world, in a world with so many inequities, but it is important that we do that. Now, that is a brief sum up of the three interventions from my point of view, which I was asked to do at the beginning, but we now come to a very interesting point in our agenda, and that is to look at all that from a more practical point of view, from someone who has had the obligation to put all this into action, what we have discussed from a more philosophical, scientific, or administrative view, and that is Dr. Dimitri Daskalakis, whom I would like to introduce now as our next speaker. He is the director of the Center for Disease Control and Prevention's Division of HIV/AIDS Prevention. He has served in a number of capacities in both healthcare and public health in New York City. He has directed the Public Health Laboratory and all infectious disease programs, and he has served as the New York City Department Incident Commander during the measles outbreak, which actually was the original reason why we planned this symposium. It wasn't Corona. We had no clue of Corona when we planned it all. And he is also now in the same position as the current COVID-19 Public Health Director since January 2020. He joined the Center for Disease Control in the United States in December 2020 and has most recently been assigned the role of Senior Lead Equity in COVID-19 Data and Engagement in the CDC response to the pandemic. Dr. Daskalakis, Dimitri, the floor is yours.
Thank you very much. And I want to, again, thank you for including me in this panel and referencing the measles outbreak in New York City, which really, I think, highlighted the fact of what we've already heard from so many of our previous speakers. So like Dr. Aman said, vaccine hesitancy is not new. And so that experience, I think, is reflected very clearly both in COVID as well as in other vaccine preventable diseases. And before I talk a bit about my experience, I just want to note that, the echoes from across the world that I hear from Dr. Swami Nathan, Professor Simplichin, from you, Dr. Montgomery, are really that this is a global pandemic, which requires a global view and a global response. And that has to do both from the perspective of being hyper-local and focusing on what individuals need to build confidence to actually get vaccine, down to sort of the notions of individual rights versus the common good. So I'm really excited to be here, and we'll give some perspectives of lessons learned during the pandemic, specifically focusing on the vaccine experience in the United States. Talk a little bit about our next steps, as well as I hope some other comments that will be part of what we discussed during the panel. So I'll remind you all that 3 vaccines have received emergency use authorization in the United States from our FDA. That's the Pfizer, BioNTech, Moderna, and the J&J Janssen. To date, almost 180 million people have received at least 1 dose of vaccine in the United States. That's 54% of the population as of June 30th. And over 153 million have been fully vaccinated. That's 46%. So that's a lot of progress, but still a lot of work that needs to be done to get to higher levels of immunization. Vaccine rollout has been a fascinating process, and I think that we can all agree, extraordinarily dynamic. For us, this was built on existing systems, but also many of those systems required extra attention to be able to rise to the challenge of not only doing a standard vaccination effort, but one that is unprecedented in scale. It's not something that we have done before. And so really something of this scale really required really close looks at what our current systems are, existing systems, and how to further improve them. I will give you a really important milestone. So as of week 26, more than 375 million doses have been ordered and 371.5 million doses delivered. So as a milestone, that compares to 4 years of our Vaccine for Children's program in the US. So in other words, in 26 weeks, that same system with some tweaks ultimately delivered 4 years worth of vaccine. So really, the scale is massive. It's important to realize that it's not just about public health and not just about public health authorities. We have had very important interactions with stakeholders. And for us, the stakeholders that we heard from others are very similar, put within our context. Our most important stakeholders really focused on the vaccine programs in the United States. We had our jurisdictions, that's all of our US states, territories, and certain cities that are directly supported by us in terms of vaccine delivery. Our federal entities, so organizations like our Department of Defense, Department of State, and our very important Veterans Affairs group. And then also, this was not about just government. Very important private partnerships were critical to be able to push forward the agenda of moving vaccine and an immunization program forward. That includes hospitals, very importantly for us, pharmacies. Retail pharmacies have been a critical piece of our work, and also distributors who work with us in peacetime for vaccines, but have really had to step up the work that they've done to be able to rise to the occasion of such a massive effort. The vaccine response has been an evolving effort, and it's really been based on vaccine supply and the dynamic nature of vaccine demand, which we've already heard many speakers refer to. We began by starting to get vaccine to the people, and now it's about both ensuring that the vaccine is near the people, convenience and access, and also bringing the people to the vaccine. When COVID vaccine first became available in late 2020, there was a limited supply. We were working in a scarcity model to ensure access to vaccine, both in supply and proximity to people who could benefit from it. Initial strategies focused on vaccinating people at highest risk. So there was a prioritization. So people who were at highest risk for COVID outcomes, or potentially are in settings where they could be susceptible to infection and then further transmission. So that included frontline workers and groups more vulnerable because of their underlying diseases and age. With increased availability, that changed. Prioritization fell away. And the challenge is now generating demand among people who have not been early adopters of vaccination. So really, we've achieved a lot in terms of getting the people who were willing. We've achieved some in moving the movable middle population who is considering vaccination, and have work to do to get deeper into the same group that may display vaccine hesitance or lack of confidence for other vaccines and preventable conditions. So the way to address vaccine hesitancy is, as we've heard by many speakers, by building vaccine confidence. And now that is a multifaceted concept, and it's based largely on trust. And that trust needs to be based on access to both clear and honest information. So we really think, or I think of vaccine confidence really in 3 buckets. It's trust that patients, parents, and providers have in the recommended vaccines, so the product, the providers who administer the vaccine, so the people who put shots in arms, and the processes and policies that lead to vaccine development, licensure, manufacturing, recommendations for use, and surveillance of adverse outcomes. In order to get someone from their home to a vaccine, a person must have trust in all 3 of these to really feel confident in their decision to get vaccinated. Now, I also want to focus on the fact that trust relies on a commitment to safety and the systems that monitor safety. We're monitoring for safety and effectiveness, watching updates for coverage, and making sure that people get the second dose if applicable. In the US, and I think throughout the world, there are robust systems in place to monitor vaccine safety. And a key element of building that trust in vaccines is to communicate very clearly on the vaccine safety process and monitoring systems, and provide safety data and monitoring results as soon as they are available in a transparent way, but also in a way that really contextualizes them to the actual risk of those adverse events when compared to the benefit of vaccine. I can say that our rare adverse events reporting show that our systems in place are working, and I hope are part of building more vaccine confidence in our country. So we're not done learning. I think we've also heard that from a lot of the other speakers. We're constantly learning about the COVID vaccines and are reviewing evidence and updating guidance. Again, such a massive effort, so many vaccines delivered, so many vaccines administered, means that we will be learning as we go forward. We don't know how long protection lasts for those who are vaccinated. And we are really, are focused on monitoring the epidemiology and data from studies, and to really be in a preparedness stance to be able to deliver boosters or additional doses if needed, and for the populations that they are necessary for. We're also learning how effective vaccines are against variants of the virus, of the SARS-CoV-2 virus. So as we talk about Delta, really focusing on the fact that many of the vaccines that we have show high efficacy. And so it becomes even more critical that we race to vaccinate as many people as possible to prevent further transmission of variants. We're still learning how vaccines protect people with weakened immune systems, including people who take immunosuppressive medicines. So looking ahead at the vaccine implementation efforts in the US going forward, we will continue to do surveillance of variant viruses to prepare and adapt with the vaccine response. Continue vaccine effectiveness studies so we can better understand how vaccines are working and if additional doses are needed. Making sure that we're expanding vaccine eligible populations once we have approval to vaccinate groups like children and adolescents. We need to combat vaccine hesitancy by increasing vaccine confidence. It gets harder and harder and harder as we go forward in this vaccine effort. The movable middle, we're moving them. It's the folks who are not interested in vaccine that are the challenge, and will be critical for us to develop strategies that focus both on equity and respect to make sure that we move forward on this work. Continuing to focus on equity is another critical piece of this. So many of the structures that have historically caused inequities in many diseases, including in the disease I work in every day, HIV, are similar to what are pushing inequities in COVID-19, both in disease as well as delivery of vaccine. So we have prioritized health equity at all levels of this response, ensuring that we have clear metrics to drive transparency, accountability, and monitoring of vaccine to make sure that we're actually getting the vaccine to the folks who have been disproportionately affected by this pandemic. So in closing, and before I hand it back over to you, Dr. Montgomery, so we can start the panel, I want to just say again, confidence in vaccination is key. You have to trust the vaccine, you have to trust the vaccinator, and the systems that produce the vaccines. New vaccination programs will use existing systems to expand the work that we're doing and bring vaccine to locations that people trust. That includes pharmacies, schools, for us, places of worship, churches, and community centers. And it's important to focus on a fact that, again, is very common to most infectious disease prevention. And the lessons that we're learning in COVID are similar to lessons that we've learned before. It is critical to engage your stakeholders. For example, programs that include both government and private, as well as community-based organizations to push forward the agenda are critical. Community level engagement, not just national, but local, is critical and essential to being able to move forward vaccine confidence. And finally, communication and education, really sharing transparently good information and truth about vaccines are the cornerstone to successful vaccinations and are necessary to boost the confidence and to address the hesitancy that potentially stymies our effort to have high levels of coverage. Thank you.
Thank you very much for this very engaged presentation. I think it showed very well your interests, and it was very interesting to hear what you said about truth and trust, and that I think is one of the key issues, and I think we all know that. But I have a question which I would like to put at both you, Dimitri, and Professor Semplici, and that is about the role of not only stakeholders, but communities beyond the stakeholder issue. And of course, having this symposium in the Vatican, although it is virtual, I do address also the religious, the large religious communities, especially the Catholic Church. We have a problem. You mentioned folks are not interested. I say also folks are not informed because they're not interested, and also many people are misinformed because we know there is a lot of fake news, although since 6 months I shouldn't use this word in the US, but so there's a lot of fake news around about vaccinations. how can we build up enough trust to prevent this old saying of the American author William Thackeray, who once said, the problem with half-truth is that people always believe the wrong half. Can we sort of involve Catholic institutions and, of course, institutions of all other religions as stakeholders in an information campaign to get people on board for vaccinations? First, perhaps Dimitri, and then I would like to hear Professor Semplici's answer to this.
Great, thank you. I'd love to go first and say that one of our important lessons is that this is that stakeholders, this sort of middle or higher level of stakeholders, not where you stop. And so it's critical to go to trusted messengers. And for us, really working with churches, faith-based organizations on the local level has been critical to getting the word out about vaccine. And that also means educating those trusted messengers. I think, we have in the US, the CDC and others have funded many organizations on a grassroots level through our health departments and other mechanisms to make sure that we're providing resources to the very front line, to those trusted messengers. I mean, we know that people listen to their priests, to their rabbis, and to other faith leaders. And so, you cannot do this without addressing all of the components of community and making sure that you're reaching where you need to be. I'll give one other example, which is in our retail pharmacy program, where we're working with companies that are large pharmacy chains and also some smaller chains. They partner with churches and other religious organizations and houses of worship, and actually put vaccine right where the people are with that trusted messenger. And so I think that it's not about big government, it's not about big picture, it's really about getting deep into the community and acknowledging who people trust.
Thank you. Thank you, Professor Semplici. Can I put the same question to you and ask you what you say about the role of the Catholic? I could say, I have a dream, and you understand that correctly. I have a dream that one day from all Catholic preachers will come, maybe on the order of Pope Francis, will come the idea that they speak out for vaccination, because a lot of people who are not interested or are not informed, however, believe what the Catholic Church says. Don't you think we could use this impact for a campaign, and it would be very, very helpful?
Well, may I answer?
Yes, please.
Well, as you can easily imagine, I'm not entitled to speak on behalf of the Catholic Church. Yeah. As an observer and as a member, a corresponding member of the Pontifical Academy for Life, I would stress the fact that as far as the Catholic Church is concerned, this is one of those situations where the position was made with very, very open and clear words by the Pope, which has some importance in a hierarchical structure like the Catholic Church is. Very, very clear. There is no doubt about what the Catholic Church's position on vaccines is at the level of the hierarchy, at least. When it comes to believers, to individual believers or groups or believers, yes, it is true. There are different positions for different reasons. And this is similar to what happens in other contexts. Luckily enough, I would say the Catholic Church offers open space for debate, mutual recognition, and respect. And maybe the Chancellor of the Academy would like to add something on that. If I can take the opportunity while having the floor, I would add a couple of things about something that I read on the chat and an observation by our current chair. As to the common good, this is exactly what I underlined. There are so many notions of common good. It has become a slippery slope. But when it is about the pandemics, this is my opinion, there is at least a very minimal concept we can agree upon. This is the idea of minimizing number of deaths. It is quite more controversial if it is only about the total number of deaths or something like total number of life years losses saved or even worse, quality adjusted life years. But I will not enter this very complex and controversial philosophical issue. But as to the number of deaths, the burden for healthcare systems of the disease and the impact of the pandemic upon the well-being of society as a whole, I think there can be a sort of minimal agreement on what the notion common good in such a context could mean. But it is very important to highlight, to focus on another aspect. The Ebola crisis was mentioned. This is exactly one of the example I would have discussed if I had time enough. Exactly the Ebola crisis. All our debates, our reflections, our difficult processes of decision making do not take place out there somewhere in the sky. We are with boots on the ground. We are with boots on the ground. And this means that the context, the specific characteristic of the pathogen we are talking about, we are tackling, also matter. It can matter a lot. It can matter a lot. Maybe to the point that decisions could also change, could also have been different, had conditions been different, starting, I repeat, with the specific characteristics, in this case of the virus we are fighting against. This is very important. This is also about preparedness. For the future, we do not know, because we need a rich toolbox for being prepared to deal with such global crisis. And the ideas on common good can be different. I hope that the efforts and the commitment to improve human life conditions everywhere in the world, for all human beings will remain one and the same, not only in principle, but in practice.
Thank you. That was, I think, very important. Again, to the common good, I would just like to give also some credit to our lawmakers and our politicians, because we as physicians sometimes very often consider the common good to be the best of health. We forget that for a politician, he or she lives in a rectangle, and in one corner there is health, but in the next corner there is economy, and they have to consider that. And in the bottom left corner, there is social psychological questions like, for instance, do you close schools and do you deprive generations of children of good education? And finally, and you mentioned that, Professor Semplici, in your presentations, finally also the question of basic human rights, which have to be retained, which have to be taken away from people for a period of time. So I think, and all this has to be seen in the different context of every country, different constitutions, different ethical aspects to this. So I think we are confronted with a very, very complex situation. And mentioning Ebola, of course, there the health factor would have been much, much higher than in Corona. Andrea Ammon has raised her hand and she would like to contribute, and we're very happy about that. Thereafter, I have two questions from the questions and answers section, which I would then like to put to you. But please, Andrea, go ahead with your intervention.
Yeah, thank you. It is this discussion is here about the situation with vaccines and the human and individual rights and the sort of the common good around this. But my experience during this pandemic was much wider to this issue of engaging communities. I think we have seen how should I say, in a development where at the beginning last year in March, an overwhelming proportion of the population was very willing with all these measures to go along and to follow, and everybody, well, almost everybody followed. And this broke down because the communication didn't really emphasize enough, in my view, how important the contribution also of the population to the control effort of this pandemic was. So this engagement of the community, the importance to first of all acknowledge their sufferings. I mean, that they actually are restricting their rights. But also the necessity to do so and to continue to do so. I think that is something that we missed in some smaller geographic areas, or even in countries. In some countries, people more naturally could be successful in this. But I think this is, for me, a very important deficit that I recognized from the preparedness for a pandemic or a crisis that I saw. The Ebola outbreaks have been mentioned, and I think nobody would go into an Ebola outbreak nowadays without anthropologists, sociologists, and psychologists on the team. How many of the crisis teams in our countries did have those from the beginning? No, I think so. I think we have to also here acknowledge there is a potential there in the community that we have to mobilize. It's not that we as public health or healthcare workers have to do it all ourselves. We need their help, and they are with the right motivation can be stimulated to do so. And that is something that we have to learn. For me, this is a very important lesson.
Yes, I think that is very important, and I totally agree with you. But I have a little bit of a different view. Don't you think that in all civilized or high-income countries, when populations followed us and we had no vaccination available, it was all containment measures like restrictions to meet others, etc. That meant you didn't have to do anything yourself, and that is when people followed. But a vaccination means you also have to take as small as it may be, risk yourself. You have to be active. You have to do something yourself. And that is, I think, where we failed sometimes in our communication. That is where we didn't get the people along with us. Because communication, as we all know, is not what we send out, but communication is what arrives at the listener. I think that is where we made some mistakes. But that was just an idea of mine. With your permission, I would now like to ask two questions. One is
Monty, I'm sorry to interrupt. But maybe we should also again invite all the participants, the audience, to take the floor if they want. They just have to raise their hand and we could give them the floor. Maybe they just need to get invited again, because now is the opportunity. We promised that before, and I just wanted to mention that again.
Thank you, Ramin. I thought it should be done through questions and answers. I have two basic questions and answers on the set, and one is very easy and I think could be answered very briefly. It is by Mudize and Tuti. I hope I pronounced the name correctly, otherwise I apologize. And that is about the impact of fake vaccines. Is that really a great problem and a great impact, or is that are those rather just some individual cases? Can anyone answer that question? I mean, I haven't seen fake vaccines in the European Union. Probably Andrea will agree to that. Have you seen fake vaccines in the US, Dimitri, or anywhere else? Andrea?
Yeah, no, I'm not aware, but I think it might be a problem. But I mean, my colleague from the medical agency would be much more qualified to answer this, because she would know what kind of controls there are to prevent that, actually.
Yeah. I think that's a good guide. We've seen some cases in Africa, if I remember correctly, but I haven't seen it or heard of it anywhere else. And the second question is by Ramiro Aranjo, and again, I apologize if I do not pronounce this correctly. And that question is about therapeutic approaches. We all talk about vaccines here. He's asking a special question to an antiviral agent, but let's take it away from that. Do we see, apart from vaccination, is there a light at the end of the tunnel in the combination of vaccination and therapeutic efforts? Or are we still, is the light at the end of the tunnel simply the oncoming train, which we're looking at? Can anyone answer that question? No one volunteering, so we have to leave it at that. We cannot give you an answer to that. And now I'm asking the floor again. Is there anyone?
Yeah, Monty, there is Salma Kundi, who is asking for the floor, and I think we can give the privilege. And yeah, Salma, you also have to demute yourself. Exactly.
Okay, good evening. It's evening in Pakistan, so I don't know what time you have. Anyway, it was such an interesting talk. My question is, many people have approached me and they have used the Sinopharm vaccine, both the shots. And even after 16 weeks of the second shot, this couple has not developed antibodies. So they were getting worried. They wanted to ask me, should they repeat it or is it normal? I want a question. I want an answer. What should they do? How should they go ahead?
Who can answer to that question? Antibodies.
Certainly not a philosopher. I'm sorry.
I can start, and maybe someone can also fill in. I see Andrea has also unmuted. So I think we're still learning about the correlates of protection. And so I think, though, there is an inclination that seroconversion due to vaccine and neutralizing antibodies due to vaccine are likely one of the correlates of protection. What we would say in the US for our products right now is that we don't have data for additional doses. And so my very distant advice from my perspective is that the way that the vaccine is indicated by its approval is what should be done, and keep a close tab on any vaccine efficacy data or other data that would imply the requirement for an additional or booster dose. I'm not sure if others have a perspective.
Andrea.
No, I have nothing to add. We don't have any experience with this vaccine in the EU.
Monty, we have a few more people asking for the floor. I see here Dr. Susanne Jona and Dr. Keller Mandapeta. So whoever can be unmuted first. Susanne, Jona, are you already unmuted?
Ramin, I have a problem. I can't see these people asking for the floor.
Yeah, I thought so. That's why I'm trying to help out.
That's why I rely on the question and answer.
Yeah, I do understand that, but I think Dr. Jona has been given the privilege to speak. So, Dr. Jona, if you unmute yourself, I think you're unmuted. Please go ahead and speak.
Yeah, thank you very much. My name is Susanne Jona. I'm the head of the German Physician Union Marburger Bund, and thank you very much for this interesting meeting and the presentations. I have a question. As a lot of misinformation is spread through social media, through different social media tools, do you think that the correct information has to be spread through this, let's say, same way, and might we need kind of influencer to do this for us? Because in our medias, people just don't look at what we would like to tell them. So wouldn't this be maybe a way to spread our correct information?
Who would like to answer? Yeah, Andrea.
Yeah, I think this is exactly what needs to be done, because I think the channels that people are using for their information should also be the channels that we are using for our information to spread the correct information that we do. This is why we have now produced a lot more infographics, short video clips to spread via Twitter, Facebook, and other social media, because this is where people look nowadays, and we have to just adapt to this.
Thank you very much. I think sometimes it's very difficult to fit into the same media, into the same channels as people do that want to spread misinformation. Stefano, you asked for the floor, I think.
Just a couple of observations on this very relevant point. The first one, it is true. We need to tackle misinformation, but through what means? I try to explain myself. We have, on the one side, policymakers, and who is on the other side? Always and only some scientific technical committee, or something like an ethics or bioethics committee, needless to say, including scientists. My idea is that it could help a lot. I come back to what I try to stress in my presentation. It could help a lot if we enter the idea, we accept the idea that what we are confronted with is not just a scientific matter, because it entails a lot of different challenges. And I did not mention the recommendation by Deutsche Ethikrat only because of you, my friends. I mentioned it exactly because of the fact that this point was very clearly highlighted. So it is a broader scope, the one that is appropriate to address these issues. Of course, starting with scientists, but not only limited to them. The second observation, it is nothing bad when confronted with something completely new, scientists come and say, well, we cannot say exactly what's going on. We are trying to improve our knowledge. In the meanwhile, it is completely obvious that some conflicts, different opinions may arise. Being humble makes it easier to build trust. Otherwise, it can easily happen that trust itself is jeopardized when we see scientists confronted with each other in a very harsh way, as if they had certain knowledge that are still a work in progress. This is something also very important to understand and keep in mind for the future, in my opinion.
I think you've touched a very, very important point there, because at this discussion, I have never in scientific experience before seen so much information being spread openly so quickly. And as scientists, we sometimes tend to forget that science is more about asking questions than giving answers for eternity. And therefore, we have seen in many countries that scientists changed their mind. And as everything was open, they had to do it in a sort of an open setting in front of TV cameras in discussions. And they simply had to say what I thought was the latest knowledge 3 months ago, I have now proven was not and was different. I think sometimes the public, the media did not follow this discussion quickly enough. And of course, we made a mistake by not making clear that the change of mind in science is nothing to be hunted for or to be punished for. It is the way science goes. And I think this is something where we made a mistake sometimes.
Monty, 2 more people asked for the floor for quite some time, and I think maybe we could still invite them to speak. However, we have already passed the regular time we were supposed to have this webinar. So if everyone agrees to stay online for 5 to 7 more minutes, how about we take those 2 people who asked for the floor for quite some while, and then we end this.
I have here as next Jay Pazzi, who has asked for the floor. Jay, you have to unmute yourself, and if you have a camera, please put that on. Jay Pazzi.
Yes, am I audible?
Yes, we can see at least a picture of you, and please speak up.
Yeah. My name is Jay Pasi, and I'm a medical student from India. I wanted to ask that many countries are demanding for a government document or a government ID for vaccination. So what about the refugees who have taken arms in different countries and they don't have the government ID of that particular country? So how can we support them and get them vaccinated?
I think we've seen many examples in many countries where, and Stefano Semplici has mentioned that as well, where underserved communities like migrants, like also guest workers that don't speak the language of the country, are visited by mobile teams of physicians, nurses, people able to vaccinate. And I agree with you, an official document should not be the prerequisite for a vaccination. But there is a problem, and I think public authorities do a service that goes to these people instead of waiting for them to come. And this has to do with convenience also, because some of the people simply don't understand what we are talking about because they live in a country with a foreign language, foreign to them. I think we have a firm position there that a legal document of a person should not be a prerequisite for a vaccination.
Monty, I think Dr. Mandapeta, he or she has asked for quite a while. I think she is already unmuted.
Yeah, I was calling her next, if you don't mind.
Yo.
Hello?
Yes, hello.
Hello?
Sir, I would like to give some presentation, means some suggestion to you to some in countries like India and other countries. They used to vaccinate it, but they are not properly. See, there is no deeply awareness on vaccination to the deeply to the people. Where people were vaccinated, there is no in detail explanation of the people were going to affect by adverse reactions by the vaccination. The government has to in detail in their local languages by one of the brother.
Hello, I think we've lost our colleague. Yep, I think he went offline. I don't have him on the list anymore either. So I think this emphasizes what we just mentioned before, that we have to reach the communities. We have to go out to the communities. Ramin, do you see more people asking for the floor?
Yes, Monty, there is Kathy Schmugge.
And I think
we have one more, and then maybe we have to come to an end. Kathy, can you hear us?
Yes, I can. Thank you. My job is I work in the Diocese of Charleston in family life, but I'm also a bioethicist. And I hope I didn't miss when the discussion was regarding the use of the fetal stem cell lines in the vaccine. I know that it is listed in the case of COVID, but is there any effort to try to prevent the use of the fetal stem cell lines so that those who might be repulsed or put off by taking the vaccine on that issue, even though the church has spoken, is there any effort to do that? Because I feel like that could block some people, even though the church and religious groups have spoken. I think that the idea that the fetal stem cell lines were used can be a deterrent.
Can anyone else? I'm not a specialist on the production. I must confess. Hello, who can I? Yes, Stefano.
Of course, this is a matter of serious concern for many people, especially within the Catholic Church. But as a matter of fact, I think this is not one of the major drivers of vaccine hesitancy. Also considering the fact that, as I said, very clear words have been spoken from the Pope, from the Congregation for the Doctrine of the Faith. I have the document on the morality of using some anti-COVID-19 vaccines in front of me. The more I read, the moral duty to avoid such passive material cooperation is not obligatory if there is a grave danger, such as the otherwise uncontainable spread of a serious pathological agent and so on. I think it is a problem for some people, but not a major driver. Of course, the question focuses on an issue that is to be dealt with not only within the Catholic Church, but on an issue that is long since relevant for the Catholic Church. I would like to take the opportunity also to thank Boris for his last statement. It is a very interesting observation, and maybe the topic for our next not webinar, let me hope so, but meeting in the Vatican or elsewhere.
Yes, definitely a meeting soon. I think we're all longing for the personal contact, which is entailed in good conferences and good symposia. Now we've stretched the time limits of our participants already. So with your permission, I would like to conclude now. I'm not going through all the issues again, but I think we have discussed 4 issues. One very important is we have to reach out to communities in the combined efforts of science, medicine, and multiple multipliers, like, for instance, religious communities or others. We have to, secondly, fight misinformation and fake news. Thirdly, we have to ensure solidarity, and I think we heard some very interesting definitions of the solidarity from the philosopher. And finally, we have to ensure equity, because in the long run, we will have to make sure that equity in the distribution of the vaccination is guaranteed. This would be a very brief summing up of our meeting. I thank all the participants. I thank the organizers. I thank especially Ramin Parsapasi and his team from the German Medical Association, but also the team from the WMA, from the World Medical Association, for having put together all these informations and having brought together all these participants. Thank you very much to our audience, who has been so brave to stay till the very end, because we had around 105 participants at the beginning, and there are still over 80 present. Thank you very much. I hope you're all vaccinated. And if not, I hope you will be vaccinated very, very soon. Thank you very much and goodbye.